Hi, this is Sandip Jali and Manos Berlakis presenting case 282 for the Manual of CTO Interventions. This is a case demonstrating use of hydrodynamic recanalization, or HDR, for a complex CTO lesion. The patient had multiple risk factors and previous stenting of the right coronary artery and presenting with angina and found to have an occlusion of the right coronary artery. EF was normal and he had a coronary CT angiogram that showed an occlusion of the previously placed distal right coronary artery stents with an estimated length of about 32 millimeters. We see on the MIP that there is another stent into the PDA, and there is good quality distal vessel with a distal cap at the bifurcation. This is the dual angiogram. We have engaged the right coronary with an Amplatz 1 guide. We do have the EBU in the left main, and it reflects the findings of the coronary CT. There is a stent in the distal RCA that is occluded. We have a well-defined proximal cap, and then the distal vessel fills through collaterals, and we have good quality PDA and right posterolateral. So again, tapered entry, length about 30 millimeters, bifurcation distal cap, some septal collaterals as well as epicardials from the circumflex. Our plan was to start antegrade given the well-defined proximal cap and previous stent to mark the course of the vessel, and then change to retrograde if needed. We did multiple attempts using a Corsair microcatheter along with several wires, including the Gaia Next 2 and the Sion black. And the wire did seem to go slightly inside the stents, but then it could not move any further, so it became entrapped. And this sometimes can happen when there are prior stents and there is calcification within the previously placed stents. So after multiple attempts, we decided to see if we can modify the lesion. So we had the microcatheter already partially inside the occlusion, and HDR is simply the gentle injection of about 0.5 ml of contrast, which can find its way around calcium and create a pathway for the wire to follow into the distal true lumen. This is from Salman Aren and Mauro Carlino, a new modification of the Carlino technique. And to be honest, we weren't so sure it was going to work here because the lesion was relatively long, but we decided to try it. So here's the injection. We do have some backfilling of the contrast into the proximal right coronary artery, in the mid-right coronary, but there's also seemed to be some contrast going forward, and the contrast seems to stain within the previously placed stent. We do not see any contrast entry into the distal vessel, but what we do afterwards is take a polymer wire. In this case, we took a filter XTA, either without a bend or with a slight bend, and then we see how it goes. And actually, to our surprise, the wire really went very easily and seems to track along the core of the vessel, which of course we had to confirm. This is a contralateral injection, and we like sometimes to advance as we're injecting, and we can see here that the wire is actually inside the distal true lumen. It was in the PDA, and we had a right posterolateral, so we did use a Sasuke dual loop microcatheter along with the Sion black to advance a guide wire into the right posterolateral. Kissing balloon inflations. And now we do have some antegrade flow. We see the vessel is already increased somewhat in size, and we do have an old stent within the PDA, and that was ballooned as well. So we did use different drug-eluting stents, a long drug-eluting stent from the right coronary artery and a short one for the lesion in the PDA. And after doing that, we did have a nice final result, TIMI3 flow in both the PDA as well as the right posterolateral. Now, one could argue whether we could have just done a drug-coated balloon inflation, but again, the result wasn't optimal after doing the initial kissing balloon inflation. Several lessons. The first one is that the hydrodynamic recanalization can help facilitate crossing. This was a relatively complex CTO. It was within stent, which might facilitate success, but it was relatively long, and with a bifurcation distal cap. We did have the difficulty advancing the wire. It was a wire uncrossable CTO, and by doing the HDR, we were able to create a pathway for a soft filter XTA polymer jacketed wire to cross into the PDA. And then the second point is that balloon angioplasty alone may not be enough, especially when there is diffuse disease and there is in-stent restenosis, as was the case in the posterior descending artery. Thank you very much.